Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
And here we are. Well, soon it will be we. Right now it's just myself, and I'll put up the lower third, but you can't see Dr. Gwen Vaughn. But I am Dr. Mark Vaughn. On the socials, you can find me at Dr. Vaughn, and you can also find my music Instagram at Mark Makes Sounds. I know Lindsay Graff checked it out, who is actually already in the comments. Look at that, Dr. Gwen came in. You're gonna join us. Woo! This is great. So today's show will be about out-of-hospital CPR.
Excellent.
Yeah. See, he finds out what the title is there. So let's jump right to the comments, of course, because we have Lindsay Antwine saying, "Hi guys, it's my 39th birthday today. Woo! Send me some good wishes. Absolutely, happy birthday."
I think I said this last year. You're close to my wife. My wife's birthday is tomorrow.
We should toast.
So
a Dutch Bros toast.
Oh wait, that may help.
He went cold, I went hot.
First sip.
Which is sometimes... Yeah.
Somewhere in the middle is just right.
Somewhere in the middle. Out-of-hospital CPR. Is that what the title is? Out-of-hospital CPR survival.
Oh, specifically survival. Okay.
Survival.
Yeah.
Should we jump right to the data?
Oh,
or do you want to give a little bit of background?
Well, maybe we should, let's give a little background.
A little bit of background for you.
Stories of all the people we know that have survived.
Oh, yeah, we can tell them all in detail. Out-of-hospital CPR. There was one old guy. He was old.
Is that the guy who collapsed on a golf course? I had a guy who... No,
okay, yours was on a golf...
That was my guy.
Mine was at the beauty parlor or barber. Actually, it's at the corner of Bell and Heritage Oaks.
Okay.
So you know the area I'm talking about.
Yep.
So
like a block away from the hospital.
Okay. That's one factor. But do you remember what we went to that location for?
CPR.
CPR training.
That's where we used to do our CPR training.
He has cardiac arrest next door to CPR training.
Convenient.
So the trainees and their instructor come around and they do CPR, and he survives out-of-hospital CPR. So that's my story about out-of-hospital CPR. It was a patient of ours.
Yeah.
Okay, so what's yours about the golf course?
Mine was an older gentleman, I think he's 70s, who collapsed while playing golf, and one of his buddies started CPR on him. Ambulance was called and ended up in the hospital and survived. That was a positive outcome.
Okay, so how long of a delay in starting CPR?
None. Like went down, friend went over, started. So that, yeah.
So why don't we just do the conclusion now? It pays to have friends who know CPR.
Who know CPR. That's kind of the big thing. And to be right there when you collapse, when you go down. That's,
right there.
Yeah.
Okay.
That's the kicker.
So I've got a few in-hospital stories. I have one story of the precordial thump, which we do not teach because it will never be a situation where it's appropriate, and yet...
and yet it worked for you.
And yet I had a patient who was talking to me, the eyes roll, she goes back, I look at the monitor, I see SCT.
Oh, SCT, okay.
I lay my...
Yeah, with SVT, yeah.
Yeah, you're not going to do it in systole.
You do that.
I lay my hand down, elbow touching the body, and let the weight of the arm, it's not a wham, it's the weight of your arm on the sternum. Mm-hmm. She wakes up, resumes conversation.
like it never stopped.
And then she was being taken up. This is at the emergency department at Kaiser. And then she's been taken up to the floor, and they had the monitor, with a handle, a little
that little thing.
Box.
Yeah, I know what you're talking about.
With the EKG reading on it. And same thing happened again while she's going up.
Yeah.
So I went over.
You did it again.
Same thing.
Twice.
Is my room ready? So that was not CPR, but
no, that is not
close. It was a closed chest percussion.
Yeah, intervention.
Yeah,
we'll call it that.
Yeah. So that was in hospital. Why do we divide it up between in hospital and out of hospital? What's this division here? Why differentiate
So in
between the two.
hospital, you can actually know what's going on. So that's a big thing. Monitoring.
So that's part of it.
It's important. So you know actually the algorithm to go down and which way to go.
Because you see what the rhythm is.
Right. Yeah, because outside of the hospital, you get to the point where you do the AED, you slap those on, the AED does its own rhythm, and pretty much it's just set up to give a shock for VTAC or...
That's what's being used inpatient now, too.
Yeah, they do have those on the floor. On some of those
We
floors.
trained in the days when you had to look at
You
a
had to
rhythm.
look at it
and
figure
decide
out the rhythm, and then say, okay, what am I doing for that? But you also have medications available in hospital too, so you
Yes.
can push medications.
Yes.
which can be very helpful
If they do
in
have a
certain,
pulse.
Yeah, in certain times of CPR.
Yeah. And to use the drugs and chest compressions and not stop chest compressions if it's asystole.
Oh yeah, I remember that's the first thing they taught us. So I get up there, and it was always the medical student. So you're the medical student, so you're the one up there giving compressions. You're getting tired, and then they'd say, "All right, switch it out. We don't want to delay. As soon as he gets off, next person get on." It was.
We should point out what asystole is. I used a term there in SVT. So asystole is what colloquially would be the flat line. There is no electrical activity, at least none that's being picked up. Mm-hmm. One of the reasons that could be happening is because it's not connected.
That would be one.
That is one possible, and that has to be considered. A very practical thing. There's this whole list of things that be causing asystole, but flat line. And one of them is check the equipment.
Yep.
Mm-hmm. Know that the equipment is working. Troubleshooting 101. Try it on another patient. See if it works on them.
Try it on while they're
okay. I guess we don't do it that way, but
I mean, if they're sitting there talking to you,
have you tried turning it off and turning it back on yet?
It's like the call desk, the help desk for CPR.
I have somebody with a foreign accent walking me through. Have you? Yeah. Have you checked
strange.
for a pulse?
The guy's talking to me, but it says he doesn't have.
That's what 911 call is.
Oh yeah, essentially.
It's calling.
It's
phone support is what it is.
Oh, there you go.
Yeah.
Yeah, that's true.
Okay, let's go through some comments here because we actually do have some.
We actually good question. Let's bring up those comments.
So we need to get caught up on
happy birthday.
Okay, so yes, happy birthday. Oh yeah, of course everybody's saying happy birthday. So I knew Dr. G's wife was very close to mine.
And very close to
a wife's
Valentine.
Apostrophe S because she's talking about birthday. There we go. And then Lindsay always asks, is it true if you're not certified in CPR, you can do more harm than good? Oh, you can if you're certified too. Next question.
So there are, what are they called? Good something laws.
Good
Samaritan laws where you can't be, charged or, sued for doing that. If you see somebody go down.
You can still be sued. It's just a matter of how much protection you have.
Yeah, you have some. If you went in with good intentions that you were trying to help the person, then So some CPR without a pulse is better than none. I can tell you that.
There you go. So back to the question of why talk about in hospital versus out of hospital. It's all about timing and training.
Absolutely.
Timing and training.
Yeah.
You already mentioned in the hospital, you've got the monitors. An alarm goes off when somebody's being monitored, which usually they're being monitored if they're likely to experience a shockable rhythm. Mm-hmm. Shockable rhythm being when we look at what the heart rhythm is on the monitor, it's one of the ones on the list of things that it's expected to respond to electricity.
Yeah.
Depolarization. Okay, so cardioversion. So we have, and then the other part is training, doing it correctly. And of course, training has changed so much since we started in medicine. It used to be there was this whole thing about teaching people to do chest compressions and rescue breathing. And then it came to, the rescue breathing, if you're concerned about catching something from them, doing the chest compressions. And I remember being told this and thought, wait a minute, are we following the data here? Well, it was years later that I found out that's what the data shows.
Yeah.
The data shows that circulating the blood with whatever oxygen is there
still will do what needs to be done.
Getting exchange of air in the lungs just through the action of doing the chest compressions. That's pushing air out. Mm-hmm. Just like it would be if you were to blow in and then, the
breath,
elasticity of the body pushes the air back out.
Right.
But you're blowing it in. it's kind of the opposite. Instead of blowing the air in, you're pushing the air out, and then the elasticity when you let go pulls it in with the bellows action. So you'd think, wait a minute, just that much? That's going to equal how much oxygen you're getting from artificial respiration? Apparently enough. Apparently it doesn't take that much.
Respiration you do need to think is an
Exhaled
expiration.
air.
So there's a lot of CO2 in there. Yeah, there's oxygen that hasn't kind of crossed the barrier there, but it is mostly CO2.
So it's somebody's exhaled air. You're getting
so
secondhand air.
So yeah,
it's been used
you're
up.
probably getting just as much oxygen from expelled breath versus just those compressions.
So that's why that's changed over our medical careers.
Right. Yeah. I remember that.
Chest compressions, and then if you have a bag valve mask,
and another person
that's going to be pulling in air or even oxygen, depending on what it's hooked up to.
Right.
Yeah, another person to do the chest compressions. Chest compressions.
Always have somebody doing that.
Keep that blood circulating into the brain, which is why.
But before you do chest compressions, call 911.
Thank you.
That's step one.
That's for help.
Annie, are you okay? Are you okay?
You in the chartreuse.
You with the face.
You with the face. Okay, let me tell you.
Help.
Where does the you with the face and the you and the chartreuse come from? It's because there's this phenomenon when everybody, in a public place sees somebody start CPR and they say, somebody call. Apparently nobody is named somebody. That's no one's name.
Yeah.
But hey, you with the face, eye contact, pointing.
Yeah.
I guess you're not supposed to point anymore. Pointing.
Still, yeah. In this
you want to be very clear
be
who you are assigning so that somebody has on them this responsibility of getting help.
Yeah. Most people have cell phones too. They can do it.
That was worth the price of admission right there.
There you go.
Or Patreon.
Worth the price of
Patreon. Yeah. Okay. Checking comments and questions here because you guys are good. Lindsay,
What happened?
I don't know. How much harm would it do to be shocked by a defibrillator when you're not experiencing a cardiac event? I'm glad you asked.
That's a great question.
The
Have you ever been
defibrillators
shocked by lightning?
the defibrillators that I trained with back in the day would do something called synchronized cardiac. It would actually be reading the rhythm.
As it, yeah.
So the paddles of the EK
at the right time
of the defibrillator are picking up and being the pads for reading the EKG. So it knows when in the rhythm to do a shock.
And I think all modern AEDs do the same thing.
To avoid causing. I believe the concern is that we could actually cause asystole.
Yeah.
If
that
you did the wrong part of the
and
cycle.
That's the answer to your question. If it were done wrong, it could stop the heart.
Yeah. So that's why it's good to do it with an actual defibrillator and not just, here's, I don't know how much. What would be the equivalent of 360 joules? I don't know. And then
not the voltage, it's the amperage.
And then it'd have to be, cardioversion is DC, isn't it? Right.
Yeah.
Yeah.
Where are you going to find a DC, that 360 joules? I don't even know how that converts to volts.
I don't remember my conversions.
Actually, amperage, right?
I'm sorry.
Oh, man. There goes my...
Is joules power?
Failing.
Because if joules is power, there'd be an equation to watts.
There you go. Because it is watts. Because most DC is measured in watts, right?
And watts is volts times amps.
Failing my... So somebody is going to look at us and say,
potential
wow,
times
how do you guys
current
not know
equals
that?
Power. There's probably some
right-hand rule.
Right-hand rule.
Wait, where are we going with this?
It depends.
Yeah.
Okay, sorry, we went on a little physics tangent there because physics is a prerequisite for medical school.
It is. I'm failing all my physics.
Calculus-based physics. Yeah, that was an interesting year. It was fun and interesting, but
it was hard.
Yeah, for a lot of homework during my junior year. Okay, so getting back to the question of how much harm would it do, you could, if the shock was not synchronized, and actually I believe in the old defibrillators, you could switch it to an
I don't even recall.
Unsynchronized setting. The automated defibrillators now, they do it for you.
Yeah,
which is pretty neat. They decide when to shock. There's no more, pushing buttons after saying clear. You still say clear, and you still push a button.
You do, because you want to make sure everybody's clear.
But the machine is what's reading and deciding if it's going to give the shock.
That's the safety right there.
Different world that we live in now. So yes, you could cause what?
Somebody
Oh my goodness,
gave
what
us
is this? And Lindsay was
that.
saying thank you to Laura. But then we get this
Auburn.
G with a super chat for
Appreciate it.
$19.99. Oh my goodness. It is Oren.
I don't know if we've Auburn before.
Auburn.
I don't remember her name. Auburn, thank
Wow.
you. Appreciate
Oren,
it.
I hope you learned to
Hope
designate
this was
someone,
worth your time. Yes.
someone to call for help.
That's what you do. Somebody goes down.
Thank you,
You.
Oren.
Oren,
Here.
you with the face. Call 911.
You and
Don't
the
do it right
chartreuse.
now.
We gotta.
Yeah.
Oren.
Dink it.
Oren. Drink it. Sink it.
Yeah.
All right. Oren, thank you. Tears from Houston. Y'all are awesome. Oh my goodness.
Oh.
Oren, you
Houston.
are awesome. Okay. Thank you. And I guess it's not past their bedtime.
In Houston, it's only what,
It's
7?
2. Yeah, I was gonna say coming up.
they're 2 hours
Coming
ahead
up
of us.
on 7. Yeah. Okay. Thank you, Oren. We appreciate that.
Yeah.
So, out of hospital versus in hospital. Thank you for pointing out Oren for me.
Yep.
In hospital, you've got the monitor, you've got the trained people.
Yep.
There is hopefully near zero delay
Right.
in getting.
Because they get in there, they see it, they go.
Okay, so what about out of hospital?
So out of the hospital,
We
don't
talked
have-
about some exceptional occurrences.
yes. So both of us
Your
have
story,
know
my
of one
story.
story each,
Yeah.
where the person was there, caught them right as they were going down. But it's most often went down. You heard somebody go down in the other room. Somebody went down and nobody knows what to do. Then they kind of shuffle around and then not eventually get that person, but then start CPR because they've gotten to the point of checking for everything. You come upon a person who's down. I'm trying to think
The
of
amount of time it
but
takes
most of the
for-
time, it's and it's not much time that needs to elapse.
We
before
don't have
things
much
go
of a
south.
window.
Yeah. Seconds. That's what we're talking here. Seconds. So if you come upon somebody, they've been down, you don't know how long. Yeah, I mean that's pretty low
I
risk.
usually
of
use the
a
figure
of a
120
comeback.
seconds. That's a lot of seconds.
For starting CPR.
For once you're having some pretty there's no definite
There's
stopwatch.
not.
The brain
You're
doesn't have a stopwatch
absolutely
and
right.
say, you're a vegetable.
Yeah.
Cross
So-
120.
So I mean,
It's a continuum.
Don't give up. I mean, don't come upon somebody and say, "Oh, that guy's been down for 120 seconds. I'm not going to do anything." But it's call CP or call 911.
It's getting there.
Yeah, I mean, if it's somebody who you know did not want CPR, don't do CPR.
Yeah, if you know they didn't.
Please,
If they got one of
please
those
don't.
pink sheets.
Yeah.
Which is where
if
this
it's your
conversation came from.
grandma who, is a what we could say DNR or do not resuscitate, which is kind of negative terms, but allow natural death is another
Oh, that's
way.
positive.
Another way to say that your 98-year-old
natural
grandma who
A&D.
just
That sounds like an ointment.
allow natural death A&D.
And what? And allow
what are we
natural
doing?
death
What are we
and
doing?
call the mortuary.
So in those cases, I mean, yeah, let the person pass peacefully. That's this happens on hospice all the time. Hospice, one of the requirements is that, hey, we're not going to do any of those big interventions because we know death is imminent, and we're going to approach that in a way that is going to elevate your dignity and allow you to pass
So we're talking about
peacefully.
a certain
But anyways,
life
this
situation
is separate from that.
where death is coming. It's not going to be
For
avoided.
hospice, yeah.
We
That's
probably know what the end cause already is. We see it coming. Medical interventions aren't going to make a significant difference.
and CPR is probably not going to be effective.
So, my big why not? Because we're talking death. If you do CPR and somebody's still alive, that's a huge difference. That's a life and death difference. So, the why not?
What's
Now, a lot of people
you're
say,
saying, like, what's the harm?
absolutely, yes. And I will point out that there is. And what I say is harm is the family that knows that, we'll say grandpa in this case, knows that grandpa is at the end.
Yeah.
They know that his condition is terminal. There's no treatment that's going to significantly extend either feeling well, time with loved ones, or life. And then CPR is done. They get a pulse back.
Yeah.
All right, where are we? He's not up and talking like the lady with the SVT in the hospital.
Yeah. Yeah.
He's got a tube in his throat hooked up to a machine causing him to breathe. This is what CPR does. Somehow my patients have this perception that they can have CPR but not have
the consequences of
the
brain being without oxygen,
a ventilator,
or needing a ventilator,
not have a tube for nutrition, not have a catheter for central venous access. You know, all these things that we do as we're doing a resuscitation, it's kind of done at the same time if you have a big enough team, or stepwise if it's all up to you.
Yep.
And these are things that are done once a heartbeat has been brought back to keep it. You don't just do CPR and then step back. If you're going to do CPR, you're committed to keep.
Kind of go down those
lines. So there is no such thing as do CPR, but don't do heroic measures. No, CPR is the heroic measure. It is the ultimate. You are bringing somebody back from the dead. So putting them on a ventilator, continuing to use electric shocks to modify the rhythm,
it's all
using the catheters.
Part of the algorithm.
Catheters for urine. Yeah, there is no having the CPR, but not the rest of it. So that's why we often have this difficulty with patients who want to mark on a form, do not resuscitate, or resuscitate.
Do resuscitate.
They do want CPR started. Oh, absolutely, I want CPR started.
But I don't want heroic measures.
But I don't want heroic measures. No.
I don't want to be on a ventilator.
No, it's a package deal. You don't do the CPR. We don't do CPR, get the pulse, and then step back and let. I mean, to us, that is the most unthinkable thing because you just did what it took to get that heartbeat. You're going to maintain it. You're not just going to. So that's why when you're filling out your physician orders for life-sustaining treatment, as it's called in many states, you're not allowed to choose. Do CPR, but don't do heroic measures or don't do, what's the term for it?
Comfort care? No, comfort care is the
other extreme.
Selective treatment. That's what it is.
The ultimate is all care.
Yeah.
Yeah, you can't choose not to have all care.
If you, you're right.
You were saying what you would choose.
Right.
Yeah, it comes all together. So you get the body, I'm sorry, has a pulse now, to the hospital. It's going to be it.
Man, you are.
I've given up on this.
Disembodying this person.
Disembodying this person. They hook him up to.
He was grandpa.
Was.
When you
hook him up to all of the monitors. And then that goes for a while because with modern technology, once we get a heartbeat back, we do what it takes to keep it until the word is given, stop, which should be designated who that is in a living will or durable power of attorney, some advanced directive, something that tells us who's the person who calls it.
Yeah.
So you're keeping them on these machines until that person says. So here's what happens. Even with insurance, sometimes the amount of money that was spent during this time could have paid for a grandson's college education or at least a year of it.
Wow, that's a very utilitarian way to look at it. But it is a reasonable way to look at it.
Yes, it is.
Because the patient, we know as physicians going into it, more than likely, we're talking 99 point something percent is not going to make it.
Yeah. Percent. Let's talk percents. So we have, where's the browser? We have a browser.
Oh, look at that.
We have results of a study. This was actually published in, well, it was available in PubMed, but it was a meta-analysis. I believe it was included in this meta-analysis. Here we go. And so you can see my cursor bouncing around there. I believe you. I don't know. Maybe can they see it? Maybe they can't. I can see my cursor. You know what? I can show you the cursor if I do this. There. Is there a cursor on it now?
Mm-hmm.
You can see that? Okay.
Yeah.
So let's get to some numbers here. And we're looking at, why don't we look at this down here? Survival to discharge, 8.6, 1976 to 1999 versus 9.9% in 2010 to 2019. Hey, they're getting better.
An improvement.
Look at that.
We're better at CPR.
Up
what
to
that means?
2019, it was almost double digits survival for out of hospital CPR.
That
Higher than it had ever been in history up to that point.
wow.
Okay, but that's till discharge. What about 1 month survival? Well, funny, it was the same 2010 to 2019 as it was 2000.
Wait, that's 1 year survival.
I'm sorry,
Selected
that's
that.
right. During 2010 to 2019, the 1 month
was
survival was the same
13.3.
as the 1 year, which was
Which went up as well.
13.3. We made it to the double digits. People surviving for a year from out of hospital CPR. That's amazing that we are able to reach that for out of hospital. Now in hospital, whole different bird. We're not even talking about it today.
And I'm pretty sure that that data was from all comers, right? We're not talking 70-year-olds and older. Is that
Right,
all
right.
Yeah. Okay.
Total of 141 individuals. If you want the breakdown of,
I'm sure they have those. Those numbers in the actual. But
I just have the
when
abstract
I
here, sorry.
when I was saying earlier that we know for some people it's a higher likelihood that they're not going to make it. That's because as you get older, unfortunately, that number goes down significantly.
It also goes down in countries that don't have high-tech healthcare.
That makes
So
sense.
Western countries with the more advanced healthcare.
Having an EMT or paramedic that's able to
the
get
training.
to the scene and has the training to keep.
But
the
also
person alive
good
on the
training
way.
of people at home, of lay people.
Yeah.
So it is worthwhile to get your CPR training. That's the bottom line of this show.
Yeah.
It is worthwhile. So when that's all comers, we know that the people who are around somebody who was trained, recognized what to do, started CPR, pointed at somebody and told them to call for help.
Yep.
Much
And
higher
just did it while
success rate.
the EMS was on their way.
So I don't want people to think, don't start CPR. I want people to think, wow, just CPR for the sake of CPR is not all the same. CPR started by a trained person, also in the right patient, started immediately, is the most chance of being effective. And if it's your loved one that and they're not, imminently dying from something already.
Yeah, you know their wishes.
A DNR situation.
Yeah.
You probably would
guess
want to be able to do CPR on them.
That's maybe the other thing. Maybe have that conversation. It's good to, especially as, if you have your aging parents or those who are more elderly in your life, encourage them to talk about this because it is something that they should be talking to their healthcare provider about, who knows their health history, who can have a informed discussion about, hey, is it time to maybe go towards that?
I'm sorry, I have to interrupt this. I just got a text that says, urgent poll.
Should Taylor endorse it?
Should Taylor Swift endorse Biden? Okay, all you people sending these political texts to me, I've had it. Every time, I'll show you exactly what I do. Report junk. Delete and report junk. That's what is happening to your political texts that you keep sending to me, whoever you are.
Whoever you are.
Whoever you are.
You know.
I'm sure they're watching this program.
Wow.
I'm sure they're one of the
Calling out.
19 watching this program.
Taylor Swift. Wait, wasn't that the conspiracy theory that she was going
I
to
thought it already happened, wasn't it, during the Super Bowl?
Supposed to endorse right after they won the Super Bowl. And
I thought it was going to be during the
this
halftime show.
celebration. No, it wouldn't be then. They had to win first. Because when they win, then she's elevated on the stage of the, and then do it there. I don't know.
Wasn't she the halftime show?
No, that was Usher. Man.
Oh.
With some special guests.
Well, then how come there was such a big deal about her in the Super Bowl if she wasn't the halftime show?
Her boyfriend.
Usher's her boyfriend?
Oh my goodness, I'm not even going down this road. Please, this is what I have to deal with, people. This is what I have to deal with when it comes to sports.
My goodness. Why do they play hockey in a bowl anyway? It doesn't make sense to me.
Why do they call it football? They don't even... Actually, they use their feet quite a bit for this one. There were like 7 field goals.
Okay, back to the show. Oren. Okay, first
You
Lindsay
come
here.
for the medical information.
Lindsay,
Just
if
stay
someone
for the
goes
banter.
down around me, we're calling the EMTs and singing.
Oh, yeah, you
yes,
are.
that's right.
Staying Alive.
There's other songs at 100 beats per minute besides just Staying Alive, by the way. But Staying Alive, much better than I Will Survive. Da-da-da-da.
Yeah, the beginning's a little.
No, we want it faster than
Yeah.
I will survive. Okay, Oren, being in the room when someone passes is profound, an honor in a way.
Can be. Yeah, that can be
It is quite an
beautiful
experience. It is
when-
interesting, I will say.
Yeah.
Yeah, it's significant. Moving on, Lindsay says, I would love a whole series of discussions about different first aid procedures. Okay.
Slap a Band-Aid on
I was
it.
going to say pressure. We just did half of the show.
So my brother did, my son did Boy Scouts for a while, and they have a first aid badge, and he was reading through everything, and he's just like, slap a Band-Aid on it. I was like, what? What about diarrhea? He's like, slap a Band-Aid on it. Like everything I said to him. Anyways.
It'll get them halfway there. We'll say that. Okay, we have, I'm sorry, we have to end the show. Sorry.
Yeah. It's our time is up.
We reached the end. It was fun. We enjoyed you. Lindsay,
We appreciate
y'all
it.
heard
Oren.
it here. If doctors say walk it off. Wait, we didn't say
I said slap a Band-Aid
we
on
said
it, not
slap
walk
a
it
band,
off.
not walk it off. There's a difference.
Walk it off.
First you say
Although
slap a
I do
Band-Aid on.
say walk it off a lot to my kids.
I was going to say, not to your patients.
Yeah.
Thank
You're
you so much.
good.
Thank you, Oren. Thank you, Lindsay, for
It's
participating
only a
in the
little
show.
blood.
Thank you to political texters who provided some fodder
Oh,
for
my
us to rip
goodness.
on. And until next time,
Yeah, I'm Dr. Wayne Baugh.
Dr. Mark Vaughn telling all of you wonderful people to stay in good health.